are actually seen daily. And so they're taking their medications daily, they're worked with daily, and these are individuals that have frequent hospitalizations, either at the El Paso Psychiatric Center or one of our private hospitals in El Paso. And so there's a big array of the types of services, again, depending on the needs of the individual. Okay, so depending on what a family comes in, what a family may encounter, and depending on what they qualify for, it will determine exactly what they're going to be able to receive. Okay, so when we talk about mental illness, what do you all think the percentage of someone that may encounter a diagnosable mental illness in their lifetime? What percentage of the population? What do you all think? Of the general population in the U.S.?
60.
60? Okay. At any given time right now, and again, these are statistics that are based on, a lot of this is self-reported. A lot of people go undiagnosed and report. It's about 26%, so it's about a quarter of the population right now. Okay, and this is a diagnosis now. How many of you guys have ever felt really, really depressed? I mean, think of some of your more darker hours. Okay, at any time, of course, all of us are going to have those moments. But what I'm talking about is a diagnosable condition where treatment should be sought, and so it's about 26%. When you think about a mental illness, what mental illnesses come to mind? What are some of the more, I guess, publicized types of illnesses? Schizophrenia, okay? Okay, depression. Depression, of course, is something that we hear about and see on a regular basis. Things that you tend to see in the television and in the media a lot of the times are more your psychotic disorders, things like schizophrenia. Things that may be associated with some of the tragedies, for example, we just saw in Tucson and not too long ago in Virginia Tech. Okay, Virginia Tech, again, that was an example of an untreated psychotic disorder. An individual that suffered from a lot of paranoia, delusional type thoughts, hallucinations, and things of that nature. Okay, and so when we kind of break it down, again, the most common type of mental illness, and one that we do not treat at El Paso MHMR for adults, are actually anxiety disorders. And so a lot of people, and PTSD being one of them, PTSD, obsessive compulsive disorder, the different types of phobias. And a lot of people, again, can go a lifetime with those types of illnesses and never get diagnosed. They basically either deal with the symptoms to the best of their ability. Unfortunately, a lot of people end up self-medicating. Okay, when I talk about self-medicating, of course, what would I be talking about? Alcohol. Yeah, alcohol abuse, drug abuse. And so there's a lot of what we call comorbidity with mental illness and with substance abuse issues. And so it's one of the things that, again, because of the nature of mental illness, and one of the big challenges that I do want to focus on in this part is a lot of the stigma that's associated with mental illness. We get a lot of individuals that do not get treated, and they may have a lifetime of a substance abuse issue, but what is never diagnosed is the underlying mental illness that may have existed since adolescence. And so it's one of those things that educating forums like this and really being able to discuss the fact that mental illness is a chronic condition, okay, is a chronic condition just like diabetes or hypertension or any other type of chronic condition. It's until people can put mental illness at the same level as those conditions, it's going to continue to be a problem. Okay, and an easy example is, how many of y'all have ever seen a billboard that shows someone that says Del Sol or Sierra Medical or UMC saved my life, I had a heart attack? Okay, yeah, you see it all the time. Sometimes you'll have local celebrities up there that might also be promoting a certain hospital or certain type of treatment that might be out there. But how many of you would be willing to be up there and say either I or my child or my parent or my brother or sister got treated and were saved at the El Paso Psychiatric Center? Okay, and it really, again, when you think about it, there's not a difference in terms of mental illness, a diagnosed mental illness compared to a chronic condition such as cardiovascular disease. If someone has congestive heart failure and they're in and out of the hospital repeatedly, whether it's for heart attacks or for just their cardiovascular system not being stable, it's the same thing with the mental illness we're dealing with. Of course, there can be a variety of things that can cause a mental illness, and it could be, a lot of the times there's a family history of mental illness that exists, a predisposed condition. But again, there's also other things that can lead to this, such as a traumatic childhood. It could be just a combination of things, chronic pain. There's a lot of individuals that have chronic conditions prior to the mental illness kicking in. And so because of the fact that if you think about all of the health conditions, the one common denominator that we can link to pretty much any condition is going to be your mental health. And it's not just, of course, related to just chronic conditions, but again, just life in general. The stability of your mental health depends on a lot with just how things are going in general, in terms of your job stability, your social life, as well as your overall health. And so when it comes to individuals that have a diagnosed condition, again, it could literally, there could be any one of us in here, anyone on this campus that has a diagnosed condition such as major depression, such as schizophrenia, or bipolar disorder, or an anxiety disorder. And the easiest way that I can compare it, I worked for the El Paso Diabetes Association 5 years, right after I graduated from UTEP. And I would come across a lot of individuals diagnosed with diabetes, some of them pretty much with just eating, watching portion control, eating a well-balanced diet, breakfast, lunch, dinner, a couple of snacks, not eating too much, putting some exercise into their life. Some people would stabilize their blood sugars beautifully. Okay, so in other words, they're diagnosed with diabetes. Once you have diabetes, it doesn't go away. Okay, it's something you're going to have for the rest of your life. However, if you have it under control, you can go to your doctor's office for the next 5 years and they will never be able to detect it. It's not a positive or a negative test. It's not like you're going to come out positive for HIV. So, but you would still have the diabetes, but because the way your diabetes is easily stabilized just with diet and exercise, your blood sugar levels are nice and stable, and a lot of the times your health actually improves with the diabetes. Okay, so that could be, someone, we're talking about type 2 diabetes, not insulin dependent diabetes, which is type 1. Then you have other individuals, same diagnosis, same condition, and again, assuming that they're all going to exercise and eat right, they have that basic foundation that they've agreed to implement in their life. If it was non-existent, they're doing that. But some individuals, even with the exercise and the diet, sugar levels are still getting a little high, so the doctor may prescribe some type of an oral medication, and sometimes multiple, because there's different types of medications out there that work on anything from the pancreas to the liver and so forth. And so with the medications, eating right, exercise, all of a sudden you get that nice stable blood sugar, right? Same condition, same diagnosis, but it's going to take medication. Then you have other people doing the same thing, taking pills, sugars are still spiking, so the doctor puts them on some type of an insulin regimen. So they're taking an insulin shot, of course, hopefully they're all checking their blood sugars 3, 4, 5 times a day. And while they're checking their blood sugars, everything is looking pretty good. So again, you have someone that stabilizes that blood sugar. That's the best outcome. Same diagnosis, but you have some individuals that can do it without medication, some people that need pills, some people that need a combination of pills and insulin. But it's all the same illness, it's just the individual's ability to stabilize is different. Then you have other people that do everything. They see their doctor every month, they're checking their sugars 5, 6, 7 times a day, taking insulin, taking pills. They do everything they're supposed to, and yet their blood sugars in the mornings are in the 400s, 500s or higher. They drop down to the 50s and 60s, and they have what would be considered something called brittle diabetes. They're just individuals that are very, very hard to stabilize. And you can have the same thing with a lot of other chronic conditions, including a mental illness. You have individuals, I've had individuals that have schizophrenia, very stable. I remember one, he was probably early to mid-20s, was diagnosed at the age of 18. He had schizophrenia, very paranoid, basically lived his last couple of teen years in his room locked up because the paranoia was so bad. But with the medication, he actually stabilized very well, was going to school part-time and working full-time. And he would still have the symptoms, but he was so stable that the symptoms were infrequent. Plus, he recognized them. He knew when he had the symptoms, he would see things coming out of the walls, he would hear things, but he knew they were symptoms. So because he was stable, anytime the symptoms got to the point where the frequency was increasing, he would try and either call the nurse or call the doctor and basically discuss the symptomology with them. So you have individuals with, the illnesses that you think are more severe, but because they're easily stabilized, they're able to function at a fairly high capacity. And so it's one of the things that with Paso MHMR, when you think of the stereotypes of mental illness, you think of, and to a certain extent, I see some individuals here that I recognize might be preaching to the choir, but some of the stereotypes of mental illness are maybe what you see on television, what you hear in the media. The homeless population, of course, a good part of the homeless population is affected by mental illness. We have programs that work directly with the homeless shelters and caseworkers. That's primarily what they do, is work with the homeless population. We have a housing program that we partnered with the Housing Authority of El Paso, where we have people that are chronically homeless. It's a motel that was converted into an apartment complex with 22 units. And these are, in order to qualify for this program, you had to have a mental illness, a diagnosed mental illness, and you have to have been chronically homeless. So those two criteria, you can qualify. And I tell you, this program has been in existence for 4 years now, and I've had a lot of hands-on experience with this program. It's real, very interesting because, of course, with this particular population, there's a lot of individuals that have substance abuse issues. They also have had issues with violence, either being victims of crime, they themselves have been involved in criminal activity in one form or another. And so you give them their basic needs are met, their shelter is met, they don't have to worry about utilities, any of those issues. The caseworkers work very closely with them to make sure that they have things like their food needs met, whether it's food stamps or working with the food pantries in El Paso. So all their basic needs are met, but again, just with the fact that there's a lot of problems with that led to their homelessness to begin with. It's been a real interesting program that we're constantly working with law enforcement. We work with the fire department as well. And to a certain extent, there's successes that we've seen there. Individuals that have graduated from that program have been able to move on their own because they were able to stabilize their overall health condition, not just their mental illness, and been able to function either by getting a job or working with Social Security and getting their disability benefits. But again, it's been one really interesting project because again, you're having individuals that are basically living together in the same complex, and just a lot of the social issues that come with the homelessness, from being victimized, being exploited, to having to survive. And so, again, going back to the stability with a lot of our individuals, I'd say the majority of the individuals that receive services with us see the doctor every 3 months, see their caseworker every 3 months, and again, it literally could be anyone in this room right now. I've had individuals that have full-time jobs, they're professionals, they have their degrees, but again, because of the access to care, they prefer to receive services with us, and in doing so, they're able to get the medications, whether it's through Medicaid, Medicare, or through their private insurance, or a combination of that, and they're able to make sure that their needs are met and function. And again, when we talk about mental illness, what we refer to as recovery. And with recovery, it's basically every individual's recovery will be different, and it's trying to get every individual to reach the highest level of independence, the highest level of being able to function in life in reference to being with family, being with their, whether it's at jobs, at their employment with their coworkers, and at the same time being able to have the stability of their mental illness to the point where it's the symptoms are, if not non-existent, at least minimized. Okay. And so going to the more severe population, when we look at problems that we have with mental illness, the big issues that we deal with is that if you have, again, someone with diabetes or someone with a cardiovascular disease, if their condition goes uncontrolled, where are they going to end up in? Yeah, they'll probably end up in the emergency room. Anywhere else where they might end up in? For a heart attack? No, I'm talking about cardiovascular. If someone has a heart condition or if they have diabetes and their diabetes is completely out of control, they're ignoring it, where are they going to end up in? The upper room, right? Yeah, they might end up, of course, they can end up dying, but they're pretty much going to end up in the hospital, right? In the emergency room. When they come in, they're going to be treated, and that's what's going to happen. And then you see, you hear about this. Sometimes you hear about this in the media, where UMC has a lot of healthcare costs because of the underinsured or uninsured population that they're dealing with. And of course, you hear that nationally all the time. There's all kinds of things that you're hearing about national healthcare coverage. Okay, the difference is with when someone has when someone has a diagnosed or undiagnosed for that matter mental illness, and they are unstable and they are having the symptomology for that illness that is getting to the point where they need to be hospitalized. Where do they end up in? They're different places, but let's kind of talk about them. Okay. Yeah. A lot of the times, because of the illnesses that come with, whether it be schizophrenia, it can also be depression or bipolar disorder. Bipolar disorder, of course, you have the symptoms of a major depression, and then you have the opposite spectrum. You have the mania, the manic episodes. And with these types of symptoms, of course, whether there's things like substance abuse issues that might be coming along with self-medication, or even just, again, when you have any of the psychotic disorders, just the symptoms in general, where someone is just acting out, it's not something that we are used to dealing with unless you have some experience with it personally or professionally. And so you have individuals that act out, if they're acting out in public, whether it's here on campus or whether it's at Walmart or just out in the street. Law enforcement a lot of the times is involved. And we actually have a pretty good-sized group that's called the Jail Diversion Committee that work primarily on looking at that. And that's a really complex issue. Who do you think would be in the Jail Diversion Committee? Just in terms of agencies. El Paso MHMR, who else?
The police.
Okay, El Paso PD. Probation department. Okay, the hospitals. Or El Paso Psychiatric Center.
Maybe one agency to work with diabetes or something.
What?
Association or.
Okay. Okay. Those are all right. Who else? There's a few more. Okay, we also have the courts, the district attorney's office, the public defender's office. Who else? Who else am I missing? Sheriffs? We have the sheriffs, and the sheriffs serve a dual role, because of course the sheriffs serve the county in terms of law enforcement on the streets, but also at the jails. Okay, and again, there's the homeless actually we have a homeless coalition. But there's a lot of participation because of the fact that it's a very complex issue. If you just kind of worry about your part in terms of illness, it's not going to worry. Everyone's got to kind of put everything on the table so they can understand the complexities of dealing with this population. And the thing is that it's not a huge part of the population. Like I said, when we talk about mental illness, there are a lot of people that have mental illness that, and I really wish we could do a lot more to shatter the stigma with mental illness, because if people were not ashamed to get treated for it, and if the families that support, and I've seen a lot of good support systems with individuals that have mental illness, and I'm telling you, it's not easy. Especially, I mean, I have people that spend a lot of money in terms of even getting attorneys for guardianship, because they know that their brother or their sister, their child or their parent cannot make decisions because they have not reached that level of stability. And then there are some individuals that are hard to stabilize, plain and simple, even with taking their medication. Okay? But with the jail diversion committee, it's one of those things that there are individuals with mental illness that commit crimes, and unfortunately, the crimes, I mean, are severe enough where they're going to end up in jail, and it's not going to be a free pass. I have a mental illness, that means I can do whatever I want to get away with it. Just show up to court and say, I have schizophrenia, let me go. Just send me to the hospital for a few months and then let me go. It's not that type of a jail diversion. What it is was this individual in a state of mind where they normally would not have, had they been stable at that moment, would they not have committed this criminal act? And so it's one of those things, and believe me, the district attorney's office, law enforcement, they're looking at the crime first. They're not, it's not one of those things that it's just, it's a constant get out of jail free card. Okay? But it's a real complex issue that we have to deal with on a regular basis. Okay, where else besides law enforcement or in jail, where else is an individual, if besides the emergency room, are they going to end up with? Yeah, homelessness. Okay, so again, it can become a homeless population. And again, there's a component with the homeless population where a lot of the times it's actually the homeless are victims of crimes. They get exploited. And I'm telling you, we work very, very closely with Adult Protective Services to work on this. And there are, if you haven't been exposed to it, there are a lot of bad people out there that they'll take $20 from the last $20 that an individual might have for the rest of the month. They'll take it like that if they can. I mean, we've had, I've had individuals, we've had a homeless person that diagnosed mental illness, was actually fairly stable, but still was living in the shelters, got his back pay from Social Security, and we had an individual that basically took $5,000 from this person. And unfortunately, the person was the homeless, this is a homeless man, he did not want to press charges. I mean, it was pretty much cut and clean that he had it, but because he himself did not want to press charges, the police could not do anything. And so it's one of those things that the exploitation that happens with this population is real prevalent. And if you're a predator, predators, whether it's any type of predator, if you prey on children, you prey on adults, that type of mindset, what characteristics you're looking for. And so we see it on a constant basis. Okay? So the ripple effect of someone that does not have a mental, a stable illness, again, think of what we talked about with diabetes, the ripple effect goes beyond just the healthcare system. And it's one of the things that for those of you that are in public health, I worked for the health department for 8 years, it's the same concept, it's real hard to get individuals to understand, again, whether it's the general population or whether it's your legislature, at the state level, at the local level, at the federal level, it's real hard for people to understand that prevention is the way to go. Because the cost, and again, these are just figures, estimates, the cost for us, on average, for all the adults that we serve, to serve them for a month is about $100 a month. Okay? For someone in jail, what is it? It's about a little bit over $100 a day. Okay? For hospitalization for 1 day in the emergency room, it can easily $1,200, starting out just for ending up there for a few hours. Okay? So again, the cost of prevention, that's just the basic cost. Then you look at the ripple effect of what happens with individuals that are where recidivism is a constant thing. Whether it's recidivism in the hospitals, and those are individuals that qualify for our ACT program because of the fact that they're in and out of the emergency room, in and out of our psychiatric hospitals. They get a lot more attention, and of course the cost is going to be there. But again, even with that daily contact, it's going to be a lot cheaper and a lot better for their overall health in the long run to get treated on a regular basis. Again, most of the individuals, though, with medication and some case management, and for some even case management may not be necessary. It's one of those things that it's trying to find that right combination of medications and seeing if there's any other resources. And resources can be, again, if it's adolescents working with the school districts. Within our programs, we have supported employment programs to try and find individuals part-time work, full-time work if they're capable. It's trying to get all the resources put together and working with other agencies. There's not one agency in El Paso that can do it alone in treating almost any population that we talk about. But trying to get everything put together, it's going to make the ability to have a successful recovery a lot more likely. Okay, and so when we talk about the medications, again, the psychiatrist has to find the right combination of medications, and then of course, if someone is self-reporting accurate symptoms, it's not that hard for someone, one of our clinicians to actually prescribe the medications, and they do so on a regular basis. But it's that reporting, self-reporting the symptoms is also a big challenge. And a good way to think about it, I mean, I don't know if anybody here takes medications on a daily basis, but how many of you have ever had to take antibiotics for, I don't know, a respiratory infection? Okay, when you're feeling, when you finally get to the point that you say, I need to go to the doctor, I need some antibiotics, I feel horrible, and you get that prescription from Walgreens, Walmart, wherever, how good are you? You're supposed to take it 2 or 3 times a day. How good are you about taking it when you're, the first one you get home? Usually to start off with, we're pretty good, right? You're supposed to take it twice a day, you're doing it like clockwork. How many days before you start to feel better?
5.
Okay, sometimes even less, right? Usually, most antibiotics you take for 10 days, sometimes 14. Okay, once you start taking and you start to feel better 3, 4, 5 days later, how many of you guys take it for the whole 10 days, for the whole 14 days? I mean, I've found prescription bottles and medicine cabinets sometimes when you're cleaning things up that are 3 or 4 years old and they're only halfway taken. Okay, and to be very honest with you, this last summer I got a case of bronchitis, which I've never had. It was, I guess, an allergic reaction to something in the air, and I mean, I literally could not breathe. And so the doctor put me on a little packet. It was a regimen of it was like a steroid. And the first day was like, I don't know, 8 or 9 pills, and then each day it tapered down to the last day. I think it was 1 pill. I didn't get past the second day because it was like 2 for breakfast, 3 after lunch. I mean, it was real, and for me, it was just remembering to take them. And so after the second day, I knew I wasn't going to be able to take them correctly, so I just stopped, which again probably wasn't a good decision. When we talk about individuals that have a mental illness, unfortunately, especially a lot of your psychotropic medications, the side effects for these medications can be pretty severe. And recognizing that there are actually medications that get prescribed with those medications to treat the side effects. Okay, so in other words, imagine you taking an antibiotic and the doctor says, okay, but this antibiotic has these side effects, so I need to prescribe you this medication to treat those side effects. Have you guys ever had to deal with that personally? Okay, so you're talking about 2 medications right off the start, and then the medication that treats the side effects can also have side effects. So it's one of those things that the psychiatric medications, the new generations of psychiatric medications that are out there are really improved compared to what existed 30, 40 years ago. But again, it's one of those things that a lot of our individuals that get, and of course, we try and monitor side effects very closely, and not just, of course, with El Paso MHMR, but anywhere that anyone is prescribed these medications, the side effects are something that are taken very seriously. But if you have a condition that you're getting treated for, and let's, again, a mental illness, and you're really feeling pretty good, you know, do you really want to take those medications? I mean, some of us, it's just hard just to remember to take them. It's just waking up and knowing I have to take so many in the morning, so many in the afternoon, so many in the evening. Just taking them on a regular basis can be a challenge for some people, including myself. Okay, just to be, you know, having that kind of a schedule that it's on where you can be on automatic, where you don't even, you know, you take them by every day. And again, we do what's called med monitoring on a very regular basis with a lot of our individuals that need additional services. Where we have someone go out there, whether it's on a weekly basis, sometimes on a bi-weekly basis. It can be anywhere from daily, again with our ACT team, to a weekly or twice a week or bi-weekly, depending on what the need is. And so we set, you know, we get the little meta sets and we set everything up for them and we discuss the medications and really try to encourage someone to and engage them to take that type of responsibility for themselves. But again, if you're feeling really well, and you're having the side effects, you know, there are times where we have individuals that stop taking them because they're feeling good, they're not, their symptoms are almost absent. But again, for some individuals we have, once they get off the medications and they stop taking them, the symptoms can come back on gradually where they may not recognize the symptoms, and then they are, you know, on a course for really hitting the rock bottom again. And I can think of this of an individual. It's actually a friend of mine's sister who had schizophrenia, graduated from UTEP with a degree in education, and developed schizophrenia. Actually worked as a teacher for several years and did very well, was very stable. But again, this individual had problems with staying on the medications. The first time I met with her, she lived in a home, postings around the yard, again, dealing with a lot of paranoia with the Mexican cartels and the federal government. And what had ended up happening is because her paranoia and her hallucinations had gotten so bad, she had actually dismantled the plumbing in her house. She had put big rocks in her bathtub because she felt people were coming in through the plumbing. She had dismantled the toilet. She was actually defecating in buckets and then discarding that herself outside in the trash can. But yet she would see feces and urine in the house all the time, and she thought people were coming in doing that. And it was her cats. But the thing is that because she would not allow family members inside the house, they did not know how bad it was. And it was eventually until we did what's called an emergency detention. When we have, and Jesus will talk about this in more detail, when someone is in crisis and they need to be hospitalized, they can go in voluntarily, and where they're voluntarily willing to go into the hospital. But of course, a lot of individuals either don't want to go, they don't recognize that they may even have an illness, and so it's not until, and it's kind of a catch-22, we have to wait until they get unstable enough, until they're bad enough where they are deemed a danger to themselves or a danger to others before we can actually get them to be hospitalized. I have had family members come to me, and Jesus probably a lot more than I have, where they come to us and discuss the symptoms that, again, that their child, well, if it's a child, if it's an adolescent, the parent, of course, makes the decision. But let's say it's their child that's an adult, or a brother or sister, or a spouse for that matter, or even a friend. They come to us and they're discussing all the symptoms that they're having, and then we'll go right and we'll discuss this with the individual and say, no, I'm fine, and they don't know what they're talking about. Well, we have to take, we can take collateral information, but if a person is not willing to go voluntarily, we can't force them to go to the hospital. And so what we have to do is we have to wait until they get, the symptoms are bad enough, where we actually have to get what's called an emergency detention order. That's sent to a judge, and the judge will sign, and then basically a warrant is put out, not for their arrest, but to basically be sent to the hospital. And so it's not until we have individuals at that level of instability that we can actually get them, if they're not voluntarily wanting to go in, it's a process that has to take place. And to a certain extent, there's good intentions and there's good reasons there. A lot of family members have said, have told me, you know what, if anything happens to my mom or my brother or my sister or my son or, you know, whoever, you know, they're gonna hold us responsible. But we have our crisis intake team, that's all they do. I mean, that's their job is screening people every day for crisis, whether it's voluntarily or for emergency detentions. And so they're able, I mean, their process is a perfect, of course not, but it's pretty good in that if a person is not at that point and they don't meet criteria for hospitalization, again, it's a catch-22, because if the family member knows that they're not taking their medication and they are going to get worse, and of course we can assume that they are going to get worse, it's one of those things that, you know, do we hospitalize or don't we? And the reason I say that there's good intentions behind the laws is because think of you yourself having your rights taken away for a moment, where you know, you're saying, you know what, you are a danger to yourself, you are a danger to others, and we're going to have to you know, put you in the hospital. And so no one would ever want that to happen, and so that we don't do it prematurely, it's one of those things that you have to meet that criteria. So again, it's a catch-22 in that it's good for some reason, it's bad for others. Okay, and so when we look at individuals that are in crisis, and we're trying to determine whether or not individuals need to be hospitalized, or if they're receiving services with us, what we can do is try and do other interventions as well. And again, if they're not taking the medications, it's one of those things that outside of visiting them daily and actually seeing them take their medications, it's not going to be something that you know, we can monitor very accurately. And so of course we have to go by self-reporting. And for some individuals, it's funny because you have some individuals that will not take their medications, especially once they start feeling better, that they'll stop taking their medications. And again, for sometimes for good reasons, because of the side effects, or sometimes it's not even intentional. And then the one other spectrum that we have is we actually have individuals, because of some of the medications and the feelings that the feelings that they get from the medications that are good, they actually overtake them. And not with intentions to hurt themselves, but to get the feelings that they get, and possibly that they are wanting to get more of. And so they start taking them on a regular basis, where eventually they're out of the medications way before they're supposed to be. And so it's funny because we will see both spectrums, people that are not taking them, and then people that have, that they're what we call our med seeking. We had an individual just this past week that the mother and the son are both receiving services with us. Mother has come into our office repeatedly wanting her son hospitalized. Clearly does not meet criteria. He actually just got out of the hospital about 2 weeks ago with a prescription and with medications, and his medications are non-existent. And what we're finding out is that the mother is actually med seeking for his meds. So mom is taking his medications, and individual is not. He has some anger issues, and so he tends to have exhibit some violent behavior. And so it's one of those things that there's just a lot of complexities with some of the population that we deal with when the stability is not there, and the ripple effect that we feel can easily overflow into a lot of the public sector. Yes.
If somebody does, if you deem it necessary for an emergency detention, typically where do they go? Are there multiple options, or is there kind of only?
One of the easy options is they come through us, but there's, I mean, it's basically filling out the form, and you can deal with the courts.
Where would they be held if that process was?
Oh, okay. What happens is, once the emergency detention is executed, okay, that they fill it out, they get it to the judge signs it, then the warrant is put out for their arrest. Law enforcement will pick up the individual and then bring them to our 1600 Montana location. And then from there, or sometimes they have to be medically cleared for any reason, they'll go to an emergency room. If they go to the emergency room, the ER staff medically clear them there, and then one of our crisis specialists will actually go to the emergency room and then do the assessment there. And then from there, they are then transported, and this is assuming that there are beds available at the El Paso Psychiatric Center. If beds are not available, there's what's called diversion funds, and again, this is something that I'm sure you all have seen it in the newspaper. One of the big problems that we have, specifically in El Paso, and it's really in Texas. Texas, unfortunately, does not fund mental health very well. We're 49th or 50th in other words, we're either last or second to last in terms of the way we fund mental health compared to other states. And so, because of that, and because about 99% of our funding is either state, federal, or grant funded, we really don't get a lot of local dollars here. If the beds are not, if there are not beds that are available, then sometimes individuals are waiting. They're waiting in the emergency rooms. I mean, it's one of those things. We cannot detain individuals at our office. We just don't have the facility to do that. And so, but if a bed is available, then they are taken to the psychiatric center, and then they are kept there, and they actually hold court there at the psych center. So what happens is, usually on a weekly basis, the individual will come in front of the judge. They will state their claim and say, you know what, I don't want to be here. I'm stable, and I want to be released. The judge will state his current assessment of the individual, what symptoms they're displaying. Our caseworkers will be there again sometimes to offer collateral information. And so it's a process. An individual may be there for a few days, and they may be there for months.
How many beds are there?
At the psych center right now, I believe there's 75 adult beds. I forget how many I have. Jesus will actually be able to tell you right off the top of his head. So again, it's one of the things that what we're hoping to do, and what we're constantly working with our local officials, is to try and get some additional local funding here to try and meet the needs. Well, really, again, as I mentioned before, the money is best spent in outpatient care. It is. We have programs throughout El Paso. Again, we're the mental health authority. And with the mental health authority, what that means is that we authorize the services. I think that starts at our front door, which is the intake department. You come in, you get assessed. Let's say it's not a crisis, but you come in, you've been having these symptoms, and usually with a mental illness, at what age do you think something like schizophrenia, what are the psychotic disorders? Where do they usually, when is the onset? At what age? 18. Yeah, late teens, early 20s. Okay, bipolar disorder? Yeah, again, around the same time. Okay, depression again can start early on. We've had very young children, 4 or 5-year-olds that display symptoms of depression. So depression can pretty much happen throughout anyone's life, and again for lots of different reasons. Family history being one of them, and again traumatic, some type of a traumatic situation that could have happened can of course trigger a depression. And depression can be, as a major depression means it's pretty much there. It's just a reoccurring, even if the symptoms are minimized and sometimes non-existent, the treatment with medication is continuous, or at least recommended usually by the clinician. Okay, but for individuals that come into our intake unit, they come in, that's the front door, and once they if they qualify for services, whether they're a child, adolescent, or an adult, then they have options. We have 5 or 6 private providers. These are providers that they're in private business, and they contract with us. We have Atlantis on the Far East side, not too far from downtown. We have a group called Cambridge. And so again, it's basically an outpatient clinic that has everything from psychiatrists, nurse practitioners. They have rehab workers. Rehab worker, again, is in an easy way, they're like a case manager. What the authority does, and this gets a little complicated, but I'll just kind of give you a nutshell of what it is. The mental health authority, this is the case management. They authorize the services. So you come in through the front door, you qualify for services, you're given an appointment for a case manager So the case manager then does what's called a TRAG assessment, and they assess you to see what level of services you need to be at. For adults, service package 1 is the minimal services. You may get some rehab, but most likely you're going to see the case manager every 90 days, and you'll see a doctor or a nurse practitioner or prescriptions. And then from there, once the caseworker does their assessment, you get to choose where you want to get services from. And so we have an internal provider that is a safety net, and so that just so that there's not confusion, we actually separated that name, even though it's El Paso MHMR employees, and we call that El Paso Provider Group. And so they are the ones that we have the outpatient clinics, and we have four outpatient clinics for adults, and we have one for children's. That's our chance unit. And then we have the private providers, and again, those are located throughout El Paso as well. And so what they do then is they go, and that's where they see their psychiatrist or the nurse practitioner. That's if they're getting rehab services, that usually is a service package 3 or 4. We have four service packages for adults. One being minimal care. Again, it's mainly the case management and the psychiatric services. Service package 2 is only for individuals that have major depression, and it's a short-term package where they actually receive therapy. And a lot of our individuals, a lot of people don't realize this, but we don't actually do a lot of therapy, actual counseling through our services. But of course, because not one agency can fill all the gaps, what we do is we do a lot of referrals, and so there are a lot of counselors in the community that we refer to. And so if you come into our intake unit, whether you qualify for services or not, you're given resource packets. So at least you know of what's available out there to you. And so we have the Family Services of El Paso, we have the El Paso Jewish Community Center, I forget the exact title. I mean, there's different agencies that we refer to. Because again, when it comes to someone that has a severe, persistent mental illness, at least to begin with, the best approach to getting that illness stable is a comprehensive approach. And with studies and research, where the most success comes is with psychiatric medications, some case management and therapy. And so it's a combination of those things. Again, the only area where we provide actual therapy for is in our service package 2, and that's 16 sessions. Okay, it's again, depending on the frequency of those sessions, if it was weekly, it'd be about 4 months. And so that would be a service package 2. For service package 3, again, it's rehab services. And the rehab services, again, is not rehab when you think of the word rehab. It's basically a caseworker going out and doing everything from coping skills. Some of the rehab services are done in group, like anger management. Again, med monitoring is very, very common, because we want to make sure that the individual is setting up their medications where they are taking them on a regular basis. Okay. And then depending on the severity of their illness, the service package 3, there's units that are allotted for them, and the units basically come down to minutes. How often or hours, how often are they seen in a given 90-day period? And so that's the way the services. For children, it's a little bit different. The packages are reversed, but the rehab sessions are actually with the parents, because what we're trying to do with the children and the adolescent services, it's going to be the parents' responsibility to work with this individual. So there are actually curriculums that are set up to teach the parent and educate the parent on how to work with the child and the symptoms. And that can be pretty tough. Of course, we do work with the children as well, but it's really trying to give the parent the tools on how to work with the child. Of course, the parent would be responsible for dispensing the medication as prescribed, but it's one of those things that with the children, just like with the adults, we get some kids with the medications, they do well. I mean, their grades go up, their behavior is under control, and just like someone with diabetes that eats right and exercises, you see some kids where everything, just with the finding the right combination of medication. And you all know with any chronic condition, I don't care how good of a clinician you are, whether we're talking about a doctor or a nurse practitioner, it's one of those things that trying to find that right combination of medications isn't always, easy. It's not going to be, a lot of it is hit and miss, trial and error. But once they find it, you get a lot of our kids that do very, very well in school, okay? And then again, just like others, sometimes there are others that are hard to stabilize. And of course, a lot of our children, the agencies that we work with, or let me ask you before I say, what agencies do you think that we partner with very closely when it comes to the children that receive our services? Okay, definitely some of the children's homes, Leemore, Beulah, the Bear Foundation, who else? Yes, Child Crisis Center?
School districts.
Okay, definitely the school districts. There's two other ones that are, okay. Yeah, we work very closely with which, if you think of foster providers, what agency are we talking about? Child Protective Services. We're very, very closely with Child Protective Services, and there's one other one. Yeah, JPD. We're very, very closely with JPD. We actually we did this a couple of years ago, working on it, doing it again, where we actually do some cross-training with Child Protective Services, JPD, and themselves, because a lot of it is the same, a lot of our children are in all three services, either, not at the same time, they have been in the services. And with the children, a lot of our, because again, we're talking about, there's the family history component, as well as the environmental component. A lot of our adults that receive services with us have children that receive services with us as well. And so it's one of those things that we try and work at all levels to try and find out what the right combination of treatment is going to be for both the adults and the children in terms of the services. Medications, again, is just one component. And so it gets to be real, it can be pretty complex to try and balance that out. And so it's a lot of communication that needs to take place. And of course, I mean, it comes down to the individual where the effort has to be there. And if the effort is not there, then that's where we start to have, more issues come up. Okay. But it's one of those things that the services that we provide in El Paso, currently, we're pretty much, we're saturated. We've gotten to the point, and I mentioned this a little bit earlier, where Texas does not fund mental health services the way other states do. And there's a lot of other things I wish we could do, or that would decrease some of our caseworkers' caseloads, and just be able to offer some additional services that are really needed out there. But right now, we've actually gotten to the point where Texas determines each El Paso MHMR services capacity. In other words, how many individuals should you all, they project, El Paso, you should be able to serve 3,000 adults or 3,200 adults, and you should be able to serve about 600-700 kids. Where our children, we were well beyond double that for a while. If they have Medicaid, we have to serve them. But if they are, and with children, it's not that difficult to get Medicaid. So for children's services, it's definitely an issue. But for parents to be able to get the Medicaid if they qualify for, or at least CHIP, then we can work with them. But for the adults, it becomes a lot more difficult. And so we actually had to implement recently a true waiting list. And with the waiting list for the previous year, we had a waiting list, but what we were able to do is transfer those individuals from the waiting list. Some of these individuals were already in services. Some of them had been in services for years, and we transferred them from a waiting list to an outpatient clinic that was funded locally. And so with that, again, they were some of the case management and the rehab services were now not available to them, but at least the psychiatric services were available to them, and of course, the medication, which is for some individuals, that's really the main thing that they need. Others, the medication is only going to work if they take it, okay? And if you don't have, and again, I don't want to put this just on this population, because I can tell you right now, if I have to take medication for a chronic condition, let's say I develop diabetes or high blood pressure, I don't know, I honestly cannot say I would do that well with it. And not because I would fight it and be in denial and say, no, I don't need it, but just because of, I know that when I'm running around, I mean, I literally do a little mental checklist with me. It's checking my phone, checking my wallet, and I'm out the door. It's not that I take my medication, and again, just to give you an example, there's probably been about 3 times in the last I don't know, couple of months, that I've almost taken my daughter to school because I'm driving and she's in the seat and she goes, Dad, you missed school, and I'm about to get on the freeway. So, you know, you have little things like that with taking medication, you have to have that ability to really think about it. And then if you don't set it up in a meta-set, and they're all in a bottle, are you gonna say, well, did I take how many of you guys ever remember if you've taken something? Okay, so for those individuals that were put into this clinic, they didn't have those services anymore, but at least they still were able to see a clinician, a doctor, nurse practitioner, and get the prescribed medications on a regular basis. Unfortunately now, though, some of that local funding is not there, so we actually have a true waiting list. And these are individuals that either have been in services, or this may be newly diagnosed individuals coming in through our front door at our intake unit that are they have a preliminary diagnosis going through our intake unit and would probably be fully diagnosed once they see a doctor and then get a full psychiatric evaluation, but they are put on a waiting list. And so it's one of those things that, and again, you'll see this in the media, where the wait list issue is going to be coming up. And unfortunately, some of the funding for diversionary funds, when I talked about our intake unit, again, we'll talk more about that in a little while, where individuals, if they are, let's say, whether they're on an EDO, emergency detention, or whether they are on they are voluntarily admitting themselves because they are truly suicidal, homicidal, a danger to themselves, a danger to others, for whatever reason they are being needing to be hospitalized. If the psych center is full with diversionary funds, we would be able to send them to one of our private hospitals, which we have a UVH here close to Sierra, and then we have the Peak, which although it's in New Mexico, in Santa Teresa, we were just able to send individuals there only for voluntary basis. We couldn't send emergency detentions to the Peak because of crossing the state line. But with the wait list, again, I compare us to diabetes because it's very easily comparable because we're talking about chronic conditions that need medications to stabilize. But if there was a center that treated all individuals in El Paso with diabetes and there was a wait list, again, if an individual does not control their blood sugars, the eventual complications can be pretty bad. It's not something that happens overnight. Some people can go years because they never seek health care. Will go 5-10 years with diabetes, not knowing it. By the time the symptoms are so bad, or more so the symptoms from the complications are so bad, like the blindness and the kidney disease or the cardiovascular problems that they have, eventually they end up in the emergency room and they're diagnosed with, a very progressive stage of diabetes that's been under control for a long time. But that could take years. With population such as those diagnosed with mental illness, their symptoms come on, if their symptoms were non-existent, it really wouldn't be an issue, would it? With diabetes, I have seen individuals with sugar levels. When I used to do health fairs, I would see individuals where the glucose monitors would read high. And if I remember correctly, that was anything, depending on the monitor, that would be anything over 500, over 600. Okay, so which is, whenever I would see that, I would test them again. And then when I got that high word again, I would just very calmly try to tell them, what, you need to go to an emergency room. Because their sugar level is so high that, even if they have medication at home, taking a couple of pills was probably not going to be enough to drop it down. And even if it did, would it happen quickly enough? But I would run across individuals with high blood sugar levels well above 400, and they said, I feel fine. I feel completely normal. And that's one of the scary things about diabetes is the fact that you can go with sugar levels that high and not even think about it or not even worry about it and recognize that the fact that the sugar level was that high. But with mental illness, can individuals wait like that without medications if they really truly need the medication?
Yeah.
Again, and this is what we've already talked about. What do individuals that have the symptomology is there, whether it's any of that, whether it's an anxiety disorder, and again, let's talk about the most common diagnosed mental illness, an anxiety disorder. What are symptoms of someone having an anxiety attack? What else?
Shortness of breath.
Shortness of breath, a rapid heart rate, sweating, trembling. Me and Mike are mental health first aid instructors. We actually do a mental health first aid course. It's a 12-hour course, and we do cover anxiety. Okay, and so the symptoms. What are the symptoms of anxiety mimic? Yeah, heart attack. So if you are really having, especially if you don't recognize it, or sometimes the anxiety attack is so bad that it's, you know, sometimes you may not even know what it is, even for someone that knows they have an anxiety disorder. So where do they end up in? The emergency room. And again, what are the costs for the emergency rooms? And where are they going to end up? And again, if they're on a wait list with us, it means they obviously don't have insurance. And so again, those costs are going to be incurred by the hospitals. Again, and where else are they going to end up with? What other symptoms can they have with the mental illness if it's not treated? Again, there may be self-medication. There's just a lot of that ripple effect that we've already talked about. Take her medication. And child was maybe 6 to 8 weeks old, and she was at home with her sister and her dad. And and it was probably a combination of her bipolar disorder and the postpartum hormone. I mean, there's just all kinds of things that were going on. But her immediate reaction to anything that did not go away was violence. She actually picked up a plasma TV and threw it at her sister, and then she ended up, I think she hit her sister with it. She ended up at the mall, and eventually got arrested and was in jail. So I worked pretty closely with the sister. The sister did not want, the sister that was hit with the plasma TV, did not want her sister in jail, but she was not willing to drop the charges until she knew she would be hospitalized. And so what we ended up doing is we worked, again, with the sheriff's department and with the courts, where eventually the charges were dropped and she was admitted into the psych center. But even in the courtroom when she saw the judge, she went after the judge. And again, this is not someone in the right state of mind. This is not someone that had a long criminal history of being violent. It was just, you're talking about the chemistry with the brains and the ability for her immediate her defense mechanism was attacked. And we had one of our crisis workers that went to go screen her in jail, and it was just that violent type of behavior where she was, you know, the intake worker was actually fearful. And then eventually, because of the circumstances, we were actually going to transport her from the jail to the hospital, but it was just not deemed safe. So eventually, the sheriff's department was able to do that. Okay, and so when you get that type of symptomology, again, I don't want to sound like a broken record, but just the ripple effect of where individuals can end up with. The bottom line is that individuals that do not take medications, that truly need medications, they don't wait very well, such as other people with chronic conditions. And so the wait list is going to have a potential effect that you will see and hear about probably in the media. Yes?
Are there any grassroots organizations mobilizing or lobbying for better funding for mental health on a local, state, and federal level?
The NAMI, we have a local chapter of NAMI, and that's the National Alliance for Mental Illness. And so they are the group here in El Paso that advocate for that. We also have some support groups, and May, for example, is Mental Health Month. And so during that month, we try and collaborate with the hospitals, with our private providers, with NAMI, school districts, anyone that the way you really get people's attention is collaboration. Because if you're out there standing solo, the net effect is really not going to be there. And so it's one of those things that it's a growing problem. And probably the one thing that's going to make it even that much tougher, of course, is if you listen to the media, if you watch the news, if you look online, everyone, across the United States, the states are all grappling with budget deficits. And so right now, you've been hearing about strikes with state workers, dealing with their own healthcare issues. And so it's really going to be a difficult time right now. But the one thing I can tell you with the mental health system in Texas is that it is stretched about as thin as possible. And so how are there budget cuts looming for mental health in the state of Texas? most likely, but I'm hoping that the budget cuts in Texas are not, specific to mental health, are not gonna be as drastic as maybe in other areas, because legislatures know that we've already stretched it. I mean, mental health gets cut regularly as it is.
But have you identified any elected officials from the El Paso area that are,
I mean, some of,
compassionate toward this?
we have, Dan Haggerty, from County Commissioners has always been a big advocate of ours. And on the city council, again, we work with them on a regular basis. I think they recognize the problem, but again, it's just trying to find the dollars. But again, the more people that voice concerns and the more collaboration it is, the more likely they are to listen. And then that's true with any type of an issue. Yes.
If you have people who are receiving services, like somebody's already in the system and they're being monitored, or they're having weekly assistance with their meds or something, are they get, like, they have substance abuse issues, also if they're drug and alcohol issues, are they screened for that, or is that something that something within your organization does, or they have to get services for that also?
Well, we of course, that's one of our with our population, we deal with that on a regular basis, daily. So we have what's called groups for that, they're called COPS D groups, and so we deal with that. Some individuals prefer to do it one-on-one, and so we try and do that as a regular routine part of their treatment.
In-house.
Yes. However, for those individuals, again, because if you have any understanding of drug addiction, again, it's not, so many people, if they're not real familiar with mental illness or with substance abuse, it's a mentality, and this is where a lot of the stigma comes around, where it's just, snap out of it type of a thing. And so it's, what we do though is for individuals that are constantly battling the substance abuse and where the substance abuse is overtaking the actual treatment, then we try and work with Alviane, with Trinity, and looking into detox programs and in-house, inpatient rehab services. And so we're constantly referring individuals that receive services with us. The Rescue Mission also has a 90-day program. There's one individual that lives at our Siesta Gardens program. That's the collaboration that I talked about earlier with the 22 units with chronically homeless individuals. Again, I'd say probably more than half of the individuals that have lived there over the past 4 years have battled substance abuse of one form or another. And with this individual, he's been completely clean and sober for 2 years, and he went through the rescue mission. It was a 90-day program. So, but yes, we try and work with community partners as much as possible. And it's one of those things that, we just don't have the resources to do it any other way. So we're always looking at that. So it's, but it's a constant battle, and it's one of those things that, a lot of our individuals are, they're stable and they're very successful. I would say that the majority of the individuals, when we serve on an average basis, probably around 8,000 individuals between all the programs that we serve for children and adults. And then again, I haven't even touched on our intellectual disability side. That's on the MR side, but again, that's possibly another topic for another day. Okay. Any other questions before I go on anything we've talked about so far? Yes.
I missed service packages 1 and 4. What were they?
Okay. 1 is the least intensive, and then 4 is the most intensive. So 4 is what is called our acting, and it's the assertive community treatment. Okay, and basically, again, with those individuals, most of those individuals are seen daily. Maybe not 7 days a week, but pretty close to it. And some of those individuals are actually seen several times, sometimes more than once a day. And so they're checked on, and again, it's everything from making sure that they're taking their medications, to working on coping skills, getting them out into the community, and it's one of those things that because these individuals get hospitalized on a very frequent basis, more time is invested into this program to keep them out of the hospital. And so these are individuals, again, it could be a combination of substance abuse issues, be a combination of kind of like what I talked about earlier with the brittle diabetes, where individuals that actually do what they're supposed to, and still are not easily stabilized. And so it's one of those things that the doctors are trying, they may have gone through a whole spectrum of medication that is offered for their diagnosis, and they're still not stabilized. I mean, there's injectables that are given now, there's, just a wide variety of psychotropic medications that are offered. But again, that's our most intense. And there's probably about 100 individuals in that program right now, in the active. And so it's just one of those things that, and of course, the goal for that individuals in that program are to eventually get them into service package 3, and then eventually back down to the service package 1. And that's the road to recovery. And recovery for some individuals, again, a lot of our individuals can be anybody in this room. It can be someone with a full-time job, going to school. There are many times, I'll never forget, I mentioned to you earlier about a man in his 20s that was working full-time and going to school. He was going to school here at UTEP. And when you spoke to him, it could have been just like any of us having a conversation right now, but it was funny when he talked about his symptoms when he was first diagnosed, and how he would literally hide in his room with the lights turned off because the paranoia was so bad. But he had gotten to the point where he recognized his symptoms very easily, and they were very infrequent. But I had another individual about the same age, and again, this is ignorance on the family's part. I don't mean ignorance in a bad way, but just that they just didn't understand. But it was an individual, had some substance abuse issues, was involved in gangs, but he had come into the clinic with his mother. Previous to that, he had actually got into a fight in one of the groups, a physical altercation with another individual, just spontaneously, just went up and hit someone. But anyways, we met with him and his mother, and the mother basically had the mindset that her son could only do odd jobs, that he could not hold down a regular job. His goals, he wanted two things, either one or both. He wanted to go to school or work. But his mother, and he lived with his mother, and she was, again, a very nice individual. I mean, she had his best interest in mind. And she knew he had schizophrenia as well, but basically what she, and this is the question that was funny in a way, but not really. She wanted to know if there was a school for the mentally ill. In other words, was there a college? Was there El Paso Community College for the mentally ill? In other words, she could not fathom that her son could be integrated in what would be considered regular society. And so again, working with the caseworker, and unfortunately just trying to explain these things to her was not something that she could, even being the mother and wanting the best for her son, she could not easily grasp for it. And so it's the stigma that we have, and this goes, of course, way beyond El Paso and Texas, and probably even so internationally, but definitely something that we face here locally. And in Texas, is just the stigma that's associated with mental illness. And so we have done, years, we have done everything from, we've had a march, we had a mental illness, we had a fair at Bassett Center about 3 years ago, where we were at Bassett Center, we set up, and it was actually really successful. We had a lot of people coming up, asking a lot of questions, and then we had a screening of A Beautiful Mind there at the Bassett Center Theater. And so we're always trying to do speaking events, and really trying to work a lot with with children, because of the fact that a lot of the children that we serve, whether we serve directly at our CHAMPS unit, or just children that might have any type of behavioral health care issues, just the stigma that they have to deal with at school. I mean, even kids that don't have any type of a diagnosed condition, you guys have seen, of course, all the bullying and the things that kids put up with at school. Having a diagnosed condition like ADD, ADHD, depression, bipolar disorder, or having for children that live with parents that we serve, again, that those are obstacles that they have to deal with that become amplified due to the stigma that's associated with mental illness. And again, why is it that any of us would not even hesitate if, let's say, one of your parents or one of your family members, if their face was on a billboard saying, Del Sol or Sierra Medical saved my life, But would they, would you be willing to, have your face or one of your family members' face, put on there and say, Paso Psychiatric Center saved my life? And again, it's a chronic, there's no difference between these chronic conditions and those that we, with mental illness as those that we hear about every day.
What strategies have worked locally to destigmatize mental health?
And again, it's a lot of the times, the biggest problem that I think with the stigma is that there's like a short-term effect, but then people kind of forget about it. And again, the easy way to think about it is when the stigma, when the issues come up is when there's something in the media, what just happened in Tucson. Clearly, this individual had mental illness. I don't know if you all saw that there were problems with him attending the school that he was at, acting erratically. Just this past week, I have an individual that goes to school. She goes to community college, and to be honest with you, I'm not sure what's going on with her. Again, she's an adult. She has her own rights, so there's only so much that we can do to work with her. And I've actually worked with her probably for like the last couple of years, where anytime there's a problem, she'll call my office and want to speak to me. I handle the customer service, and I advocate for our clients on different levels. So if there's problems with any kind of services, they'll come to me. And so she's one of my frequent callers, and she'll call and say, my caseworker made me upset, the front desk made me upset, for whatever reason, but she, very intelligent, very capable of articulating her concerns. For about the last probably 4 to 6 weeks, she's come in, and it's her, she's just kind of in and out. I mean, literally in a conversation. And we actually, the doctor wanted her hospitalized, but we asked her if she would go volunteer. The doctor actually recommended to her in front of me, can we go in and put you in the hospital just for a little while? She said, absolutely not, I'm not going to the hospital. And she clearly is not at a stage where an emergency detention would be signed. In other words, acting erratically is not something that the judge is going to say, I'm going to take this individual's rights away. But I just saw her this past week, and again, there were times where she'll be in conversation and she'll stop, and she literally just had like a glassy look. And she would go from being real upset to all of a sudden apologizing to us. And kind of the reason she came in real upset was that she was kicked out of school. How accurate is that? I don't know. I've had other individuals that I've worked with, the disabilities office here at UTAP, and just trying to make certain accommodations for them. But basically what she said is she needed a letter from us, and that she wanted to take it to the Board of Education. And so her thoughts were they were real random, and just kind of, literally her thoughts were just bouncing everywhere, trying to really figure out what she needed, and what happened was real difficult. And so it's with this particular individual, we were looking to figure out what was going on. Is she taking her medication? We're not even sure, what's going on with her. But again, and I'm kind of balancing, going back to your original question, with the stigma, it would have to be a sustained effort. Again, probably starting with the school districts or at the school age level, and working with kids. But where we really have focused a lot of our attention to, again, is our business community and our elected officials, in trying to get them to understand that it's a problem that it really can be easily addressed, but it's a matter of whether people are willing to take that initiative. And it's just getting people to understand that if you think about a chronic condition, any chronic condition, I mentioned this earlier, the common denominator for all healthcare issues is your mental illness. I mean, when you have cancers, you have a cancer that targets a specific part of your body, there's specific symptomology, but your mental health is going to be definitely affected by it. Whether it's any type of a chronic pain condition, depression is something. Depression is probably one of the conditions that you will hear about more and more. Depression in men goes undiagnosed probably more than any other condition out there. There's a lot of, and given the current economic crisis, unemployment, we're probably just scratching the surface. I remember in working with the Diabetes Association, Diabetes is another thing that is something that's ready to burst just because of the problems that we've had for, more than 20 years with obesity and current lifestyles with, computers and TVs and non-physical activity type of lifestyles that people are leading more and more starting from childhood. But in terms of mental illness, the problem is that so much of it goes undiagnosed that by the time that you do hear, and I don't really want to touch on suicide too much, because Jesus is going to really break that down, but by the time you hear about tragedies, it's something that people eventually start saying, oh, this did happen, and there were so many things that pieces of the puzzle that fit, that were basically showing signs that something was going to happen. And if you look at the research with what happened in Tucson, what happened at Virginia Tech, it's not something that just happened out of the blue. And so it's being able to recognize those things, but again, and I keep going back to this because it's such a huge barrier, the stigma prevents people from really dealing with this. Family and friends, we get both extremes, people that don't want to deal with it. To give you one small example, I had a mother from San Elizario, very, very conservative mother, and she was very devout. I think she was Christian, I'm not sure she was Catholic, but just very kind of an introverted, kind of kept to their family unit. Well, the son was, and it eventually ended up being diagnosed as being bipolar, and he was gay. So you're talking about coming from those type of family values, and not that there's anything wrong with that, of course, but what the mother thought was wrong with the son, and the only reason he came to our unit was he became suicidal when he was at school. He was a high school student in the Socorro School District. So the counselors are the ones that actually had him transported to our crisis intake unit. But the mother thought that he was possessed. And honestly, and again, you can't, the ignorance, when I say ignorance, is that they just don't understand or don't have an idea of something like bipolar. The mother may have never heard of the condition, for all I know. But because of his symptoms and his behavior, she thought he was possessed. And so who was she dealing with? She was with the church for the problems. And the last thing that she was thinking about was, having to see by a doctor. And so it's just one of those things that it's just the ignorance that is out there for families that maybe have to deal with it directly. They don't understand that a lot of these conditions can be very easily treated, especially for children and adolescents, because the resources are a little bit more available than they are once you get to be an adult. Okay. Any other questions? Yes.
You previously mentioned that there was a 12-hour mental health training course that you guys hosted. Is that just for you and your staff, or is that?
No. We offer it to the community. Yeah, we'll get you information by the end of the day. We'll get you the phone number and everything. So, yeah, Jesus has that on his presentation. And that we actually do, just real quickly, the mental health first aid is actually, think about a regular first aid class. It's how a lay person, whether it's a family member, a coworker, one of your children's friends, or someone that you may or may not know very well, if they're starting to display some type of behavior that may eventually become suicidal, whether they're harms themselves or others, and just quick things that you can do in a first aid part before they get to resources that they need to. Okay? All right, so we'll take about a 15-minute break.
Take that.